My name is Callie Hunter, Skills Lab Coordinator at North Central Missouri College, and today I'll be demonstrating how to do a focused respiratory assessment. We're going to say today we're taking care of a 75-year-old female in for asthma, or has a history of asthma. So first thing I'm going to do is just knock and enter the patient's room. Hi Brooke, my name is Callie. Hello, I'm the nurse, and I'm going to be doing a focused respiratory assessment on you today. I'm going to go ahead and just wash my hands real quick. Okay. And real quickly, can you tell me your name and date of birth? Brooke McAtee, 12/9 of XX. Okay, very good. I'm just going to go ahead and grab some vital signs on you real quick. And I kind of see, just as I'm getting ready to do that, your respiration seems just a little bit labored. Are you feeling short of breath right now?
Yeah, I just feel it kind of coming up, like I can always feel an attack coming on.
Okay.
I kind of feel it now.
Okay. I can see that the head of the bed is elevated. So I'm going to go ahead and just check her pulse oximetry. We'll say at this point that I did obtain her pulse ox. Make sure if they do have nail polish on that you do go ahead and remove some of that nail polish. That will alter your reading. We're going to say that she's right around 88 to 89%. So I'm going to go ahead and just apply a little bit of supplemental oxygen. We do have a standing order in place. We can go ahead and do that. So I'm going to go ahead and just apply that at 2 liters. And if you can, Brooke, just try to take some slow, deep breaths for me. Okay. Go ahead and you can apply that. Let's put that in your nose. And you want the prongs facing downward. I think we've got her upside down. There we go. And going back towards the. Very good. Brooke, do you want oxygen at all at home?
Off and on, but not frequently.
Okay,
I try
so you
not
just
to.
have it as needed.
Yeah.
Okay, very good. It looks like you do have a nebulizer treatment here in just about 20 minutes. That's when it's scheduled. I'm going to go ahead and call respiratory and go ahead and have them get that prepared and administer that to you, because I can tell you're a little bit short of breath.
Yeah.
We'll say right now I can audibly hear a little bit of wheezing. Okay, her lungs do go ahead, even audibly before I auscultate. So I'm going to go ahead and just have them go ahead and bring that treatment to you. Okay? Do you feel like you're okay to go ahead and continue with your assessment at this point?
Yeah, I'm just a little anxious.
Okay. So you said that you do wear oxygen at home. Do you smoke at all?
Off and on, I have, but I quit about, it's been probably a year ago.
Oh, very good. Okay, good. It's very important that you do not smoke, obviously, with the oxygen. Make sure that you do have signs posted so nobody is smoking around you when you have that on. Okay. So do you have any other respiratory history other than the asthma? Any COPD? Anything else? Any family history that you know of?
My family's had, my parents both had asthma as well,
okay.
Or allergic tendencies. We didn't really call it asthma then. But.
Very good. And even, again, with the respiratory system, that's also affected by the cardiovascular system. So I may go ahead and ask, do you have any heart condition, any congestive heart failure, any heart problems that you're aware of? High blood pressure,
the only thing is, like, if when I take my medicine, I can feel my heart beating faster.
Okay.
Nothing.
Okay.
No.
And sometimes, especially when you give a bronchodilator, that can make your patient's heart race as well. It doesn't only affect the lungs, it can affect the cardiovascular system. So it's not uncommon for the patient to feel kind of jittery, to feel like they have a rapid heart rate, and oftentimes they will be a little tachycardic for a period of time. Okay, it's a normal side effect, it will subside. So next thing that I'm going to go ahead and do just real quick is as I'm looking at her, I'm looking for any nasal flaring. I don't see any of that right now. I can tell that she does have equal rise and fall of her chest as I'm observing her. It doesn't appear that she's got any pursed lip breathing right now, but I can tell she is just a little bit short of breath, okay, by watching her. So next thing that I'm going to go ahead and do, and I don't see any retractions or anything like that as I'm looking at her chest, and it doesn't look like she's using her accessory muscles really to breathe, okay? So I'm going to go ahead and just take a quick listen to you. I heard the audible wheezes. Are you having any cough?
A little bit, but just dry.
Dry, nothing coming up with it. Okay.
No.
Do you notice the cough is more with activity or at rest, or is it all the time?
More with activity. Like if I get up and start moving,
then you really comes on. Okay.
Yep.
Very good. Well, I'm going to go ahead and just take a listen to you here. Okay. So I'm going to auscultate her lung sounds. And again, I'm going to do a little bit more in depth than I would maybe just on the average patient that does not have any respiratory symptoms. So I would do probably at least 6 to 8 spots on the front. So I'm going to go side to side, skin on skin, back and forth. And it's very important that you are auscultating all the way through the end of expiration, okay, to make sure that you don't miss any of those adventitious sounds as you're listening, okay. And again, we're going to say that I can hear some wheezing in her lungs, which is very common with asthma from the constriction, okay, the bronchioles. And I'm going to come around below on each side. Again, I would listen skin on skin. And then I'm going to go ahead and we would wrap clear around to listen on the lateral sides, okay. So I may give her a little bit of break before I come around to her back side, okay. So next thing that I'm going to go ahead and do is just take a look at her legs. Brooke, have you noticed any trouble with swelling at all?
No, not really. I haven't noticed it, at least.
Okay, good. And her legs do not appear edematous or anything like that. Again, the reason that I want to look at that is that heart, again, oftentimes will play a part with the lungs as well. Okay, her lungs do not have crackles in them. She could just have some wheezing. But again, if she's got any issues there, that fluid can build up on her legs as well, and it doesn't look like she's got any swelling. Okay, so I'm not really concerned about that. So, can I go ahead and take a listen on your backside? Sure. Okay. So I'm going to go ahead and auscultate her lungs on her backside, again, in between the scapula, back and forth on each side, and at least 10 to 12 spots. Okay, and I'm going to have her take a deep breath in and out with each one, and really make sure you tell your patients that, guys. Sometimes if you just place your stethoscope on there and don't tell them to deep breathe, then they're not going to. Okay, so make sure you do tell them to take a deep breath, listen skin on skin, and work all the way down the back. Okay, so I'm just going to demonstrate the location. I know I'm not skin on skin, but on your patients I would like you to be. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Guys, be very cautious. Obviously, your ribs are a cage protecting your lungs. So if you're low enough that you're not on the ribs, you're not going to hear anything. Okay, you're going to get down into the abdomen and hearing things that, you know, aren't related to the lungs. So make sure that you are auscultating in the appropriate spots. Go ahead and take a sit back there. Okay. Brooke, do you feel like that your shortness of breath is a little bit better now that you've applied the oxygen?
It's a little bit.
Okay. And I see respiratory as you're preparing your medication for you right now. I'm going to go ahead just real quick and kind of follow up on that pulse ox and see if it's any better. Okay. We'll say that we apply this again, and her stats are up to about 93% at this point. The other thing that I just want to do real quickly is if I could have you lean forward. What I'm going to do is just check your lung expansion, make sure everything is good. What you're going to do is just apply your hands kind of over her lung area there. Can you take a deep breath in and out for me? Good. And as you do that, your hands are going to kind of move back and forth with the lungs as she expands them. And you want them to be symmetrical. Okay, so as your hands come apart, they should be. And it was symmetrical, chest, rise, and fall. The other thing is obviously when I assessed her vital signs in the beginning, is really to watch her respiratory rate, note any tachypnea, if she's really struggling, having a hard time breathing, air hunger can be scary, okay? So make sure that you try to calm your patient, decrease their anxiety. If there's a lot of environmental stimuli, try to kind of subside that. You may even have to ask some family, to step outside if they're causing a lot of anxiety, that type of thing. So I would look at the depth of her respirations. I would look at the quality of them. Are they regular? Are they irregular? Are they shallow? Are they deep? Those would all be things that I would note as I was evaluating her. Okay, and a lot of with your respiratory assessment, I'm verbalizing out loud, okay, to you so that you understand what I'm assessing. We don't always tell the patient that, but obviously make sure you're looking, okay, for nasal flaring, retractions, use of accessory muscles, pursed breathing. Right, is your patient in tripod position? The color, okay, the color of their skin. Other things that you can look at are their nail beds. Do you notice any, cyanosis, any blue around the lips or in the nail beds? She does have fingernail polish on, but I would want to remove so I can see if they were cyanotic or anything like that. Other things that you often see with congestive heart failure patients as well as with pulmonary patients is clubbing of their fingernails. Sometimes their fingernails will kind of have a hump to them. They'll be kind of thick. So you can kind of have your patient put your fingers up like this. And if you can see down the center of there, that's a sign of clubbing. I don't see any clubbing at this point. So those are all things that you can kind of pay attention to as well. And do you have any questions for me?
I don't think so.
Okay, I'll be back to check on you here in just a few minutes. The respiratory therapist is on her way in. The other question I just want to ask real quickly at home, are you using a peak flow meter or anything like that?
I do have a peak flow meter that I use, and I
Okay.
usually do that, at least, especially during the time of the year that I know that I need it.
Okay.
I'll use it a couple times a
Okay,
day.
very good. So what the peak flow meter is, you have to remember asthma is an expiratory illness. So patients aren't always able to take a deep breath out, okay, to expel, okay, all of that air. So what the peak flow meter does is patients will blow in them daily. It's based on different levels. There's yellow, green, red. Green is good, so if they're in the green zone, they're good to go. It's really a preventative measure, and so when patients blow in that, they kind of keep track of their level, where it's been, and so if they blow in maybe the yellow zone, that's kind of a cautionary zone. So at that stage, they can go ahead and notify their primary care provider, let them know that they're blowing in the yellow zone, and sometimes they may go ahead and treat them at that point before they're in the red zone where it's more asthmatic attack phase. It really prevents them from coming to the emergency room all the time. Okay, so that's a preventative measure, and I'm glad you're using that. Do you have any other questions for me?
I don't think so.
Okay, that concludes our respiratory assessment.